Hello, everyone. It's good to be here. My name is Justin Vinton. I'm from the Rutgers School of Management and Labor Relations, and I'm going to be talking about partnership in healthcare in the U.S. It's a case study, which in the U.S. happens at the firm level. I'm doing this with my colleagues Adrienne Eaton and Rebecca Givan, who are here, as well as Phila Townsend, who's also at Rutgers. So just a little background on partnership. I'm sure most of you in the room know, but it's essentially where unions participate with management to help make decisions across the entire organization, from the floor level to the strategic level. It's usually pushed down from the top. It's a vehicle for advancing worker voice through direct and indirect employer involvement in healthcare units, which is our setting here. Um, Frontline workers are directly working with highly educated professionals in generally demanding settings, which is an important factor here. It's adopted from the strategic level and implemented it into units, into unit-based teams. So these unit-based teams are essentially the main structure on units for partnership. It's where there's a co-manager between a manager and a union representative, and they collaborate, decide on when to meet, and facilitate engagement from the entire unit of frontline healthcare workers. Um, there's implementation challenges across units. A lot of research has shown that qualitatively. There's also evidence that union reps who are tasked with leading this UBT, from a union perspective, that they have a challenge to not only be traditional role, to engage in their traditional role as representatives to their members in the union, but also collaborate and partner with management and engage in process improvement and decision making to make the unit a better and deliver better patient care. So our questions here is, how do the roles of union representatives align with the strategic level support and expectation for UBTs, and what factors may moderate these roles, and how does it impact their role in implementing UBTs, as well as the worker voice that may come from it. This is important because we think there's an understudied role of union reps in partnership. Again, it operates the union-based teams, but there's issues in implementation, mixed voice outcomes, as well as union rep role ambiguity. So not really knowing where your role stands in terms of being a partner to a manager on the floor in a unit, or or serving your member interests in terms of bread and butter issues and grievances and other issues like that. Primarily, scholars have approached this question while we're focusing on the role, but scholars have focused this question from a structural and institutional perspective without fully exploring expectation, roles, and what shapes them. So from the top, there could be expectations at the strategic level that are pushed down, but the role of a union rep can have many moderating factors that can impact their implementation of that type of role. So what internal and external factors moderate union rep roles and are conducive for an effective UBT implementation? Voice facilitation on the ground through other frontline healthcare workers, and the expected outcomes of voice, and the most important, quality of care, which we have little evidence on, but we'll talk about voice for today. And then how may union reps have agency to shape their own roles based on these moderating factors and influences? So just as a quick example, this is what a unit-based team looks like. This is a manager and union representative working with members. I won't spend too much time here. This is our proposed model here, and kind of this, we did this iteratively and inductively. I'll focus on, this is what we're going to be focusing on today. So at the strategic level, you have the expectations and support for partnership implementation. That's coming from the top. Then you have at the workplace and unit level, you have the union rep role, which we're focusing on. We also have a separate project on the manager role. But these external, internal influences, these are the moderating factors we're talking about that we're really going to be digging into in the data here and the analysis. And that can impact UBT implementation and the operation. And then also outcomes of worker voice. And we also think there's a direct relationship to worker voice from this union rep role based on these moderating factors, and that worker voice can also shape that role as well. And I want to point out that we're focusing that outcomes are only coming back and affecting internal influences, and external influences. External are outside of the hospital. That could be, because of the labor market. It could be the pandemic, and internal influences are within the hospital. So in the U.S. healthcare setting and context, I'm not going to spend too much time here. It's highly privatized. It's relatively low unionization. In our study, union management at a hospital network have invested and are committed to partnership. Our specific research setting is a not-for-profit hospital network in Massachusetts. It's one union out of 3 union is in partnership. These are primarily clerical, technical, and what we consider lower level healthcare occupations. There's separate union for nurses who are hostile to this collaborative approach, which we won't get into in this presentation. The partnership is pushed by the union. There's a contract agreement that was signed in 2016, so it's part of their collective bargaining agreement as well. The first 5 UBTs were implemented in 2017, and there's over 75 that are now in 2024. So our sample, we did 30 to 60 minute semi-structured interviews with 19 frontline union reps and leaders across different outpatient and inpatient units. We did this with units that had UBTs, ones that were implementing UBTs at varying levels, as well as units without UBTs. So right now I'll focus on the expectations for UBTs, and I don't want to spend too much time on this because I want to talk about the findings. But so this is the expectations for UBTs, and this is codified and formalized, which I think is important here. I'm not going to read all of this. The one thing I want to highlight here is that the UBT, there's codified language that the UBT shall focus on the work of the unit with an eye toward improving the patient and caregiver experience of care. So it's not only improving the workers on the floor in the units, but also it's focused on patient caregiver. And this is also management is, knows about this charter and is on board with it as well. And they partially fund it through a partnership office as well. Ideally, you work on 2 to 3 issues and projects at a time in each unit with a UBT. So what other type of support do they have? So that's expectations, but actually structurally, what does it look like? The strategic level sponsors from the strategic level in the union and the management. There's training for co-sponsors and co-leads. There's coaches and partnership program coordinator. There's toolkits for various levels of implementation, depending on how long the UBT has been around and what challenges they may have. And then there's an engagement survey and awards for projects that they celebrate every year. So there's a lot of support. This is kind of what it looks like. There's the co-sponsor at the strategic level. There's a coach that kind of deals with implementation issues and picking projects. There's a labor co-lead and a management co-lead on the unit. And then there's the UBT committee, which is the actual UBT. So now I want to focus on moving on from the expectations that can kind of shape this union role in UBT facilitation. I want to talk about the external, internal influences and how they moderate this type of role in implementation of the UBT and worker voice. So these are internal factors that moderate the UBT implementation by union reps, and as well, and I have this highlighted, their agency to be able to help to respond to these moderating factors and help shape their own role, which I think is really interesting here. So this is a table I have. I know it's a lot, so I highlighted a few things that I want to point out. On the left column, it's the internal factors that moderate the UBT role. So this is something that can be shaped by expectations and support, but there are also other types of factors, but these are all coming from within the hospital. The moderation type, what I think is interesting here was we see examples of both positive and negative moderation that is happening here in terms of how these factors may affect the role of a union rep in their implementation of a UBT, and then how the union rep responds or shapes to this role based on these internal factors. So the first one we asked is like, why did you become a rep? Why did you volunteer for this role? Sometimes they were selected, but they had to agree to it, right? So we mainly found that this was positive, and there was a motivation to help members and the unit. They wanted to be in the know. They wanted to help improve the quality of care. And I'm going to only go through the highlighted ones just for sake of time, but based on that moderation of, the motivation, they expressed the way that they actually enacted this, and the evidence for that was they expressed to their members that unions can do more to address there's a typo there, more to address more than just bread and butter issues. They also can express to UBTs that they can prove the way it feels to be at work. And it's, again, part of that expectation from the UBT codified language. The next moderating factor internally within the unit was their personal experience and relationship with the unit manager or co-lead. So there's a positive moderation effect happening in some cases. Our managers, they always have an open door policy. They're always going to go to bat for us. And there's also negative. I think the manager needs some people skills. I just don't like them. And then plenty of communication challenges. So one way to kind of facilitate those challenges, but also even taking those positive aspects of this moderation is informally engage unit managers about other topics first, meet separately on a personal level, ask how you're doing in the middle of the day. We saw that a decent amount. Also asking for help from co-sponsors and coaches because they're there to support you. Actually engaging with them is important. And then developing trust by focusing on important projects to address in unit. And you'll see this across the board a bit, is that the focus on important projects is really key here. Actually doing something within a unit that's within the scope of the unit, but also has the potential to impact quality of care. The next one is perceived support from general management. So this isn't just your the specific co-manager within unit, but about the management of the whole hospital or upper level management. Some union reps felt that they had permission from upper management for the union to be more open with the management. And then there's the other case where it's negative. Management doesn't know the work on the front lines and having virtual only meetings. Where they wouldn't be in attendance in person. That there is a disconnect there a lot of times where union reps felt that managers don't know the work that we're doing, and that's going to impact how our members on the unit actually feel about engaging with management in a UBT. So one way that you can, try to solve that as a union rep is to leverage management support, facilitate member participation if they do it, or and try to direct attention to particular unit interests, processes, and improvements. So sharpening the focus. And then there's also, examples of informal meetings asking how you're doing to managers, just try to get them engaged. And again, it didn't always work. You could also ask for your co-sponsors and coaches, but these were some, activities that we saw union reps engaging in. Another internal factor is the personal belief that potential of UBT can impact quality of care. So you have to believe that it's gonna work or has at least the potential to do so. So the idea, and this was a direct quote, we can make a difference process. And then there was also process improvement and lean training for reps that they can volunteer to take. And then one way that they, also shaped their role through this was that they could share successful examples from other UBTs in the hospital with similar issues, and then important to stay within the scope of what is possible and important to address within the unit. So not, adopting a project that's just kind of performative or one that is actually able to be addressed and not too broad. And then the perceived UBT purpose in practice. And this is a little bit different from the other one. It can impact staff and quality of care as a positive moderation that it can take shape. And then it could also there was an example of it being used as a complaint factory to management. So one way for a union rep to shape this type of role based on these factors was working with co-sponsors and coaches to refocus the intended UBT to members to focus on quality of care. And this is getting back to that idea about the projects are important, making sure that it's dealing with the patients. So this is the internal factors moderating the UBT role and how the union rep responds to them. Now there's other ways that voice can be enacted. So there are some overlap between these moderating factors as well as the ones I previously just said about the UBT, but this is just directly about voice facilitation by union reps and their agency to shape it, either through the UBT or otherwise. Again, these are internal factors within the unit or hospital. So do unit workers have an interest in engaging? So in some cases, yes, they do. In some cases, they don't. In the positive light, workers bringing up new issues to address the unit, worker motivation to improve unit for patients, again, focusing on patient and quality of quick care. And then there's also, oh, wow, I'm running behind, aren't I? Workers sitting on the sidelines. It could be like pulling teeth. So you know what? I think I might skip through some of this since I have 2 minutes left. The other ones were perceived openness of unit managers to worker voice, whether they thought that unit managers actually wanted to hear from workers. In this case, I think, they encourage members to communicate with managers respectfully, talk to managers about how it feels to work at the hospital and be appreciated. I think that's a big one too, in terms of this mutual respect to develop trust, delegating responsibilities, their own personal experience with the unit or manager. In some cases, there was, they had been working for a long time. In other cases, they didn't know the work on the front lines. As I mentioned before, there was poor communication. So that the idea was to get on the same page with the manager about what is important for the unit, and then perceptions of the partnership in the hospital in general. And I'll skip that one. There are also external factors that I think are the union rep did not have as much a role in shaping because they had to do with external things like COVID, staffing issues, and turnover of managers. But these findings, so Harrison et al. Case study, which was in energy and food processing, they found shifts in the way the union rep role was played. There was role ambiguity in the role between partnering and the traditional role, but the partner role was subordinated to the traditional representative role. In our setting, in our case, we find that union reps role did actually change. There was more formalized support and expectations for this. There was new and informal tasks, and there was agency to problem solve. And then the last thing I want to say, and I know I'm out of time here, is that I think one of the things to focus on is that it's really important that the union rep, even just to volunteer to become one, really was doing it for the quality to improve the quality of healthcare. So I think the focus around all of this in terms of facilitating UB implementation and member voice, there was a motivation for union reps to enact this agency and to implement this because there would be moral injury to not provide good care and take opportunities to improve it. So there's the ability, motivation, and opportunity for the quality of care in healthcare, and I think that has implications for organizing, mobilizing around skills, and power. And I'm sorry I ran out of time. I would have loved to talk about that, but anyway, thank you. Yes, I'm happy to address any more. Thank you.